You come to, and there's an electric wire laying there, and there's a guy that's coding, and you could save him, what are you going to do? What's number one?
Make sure you're safe.
Scene safety. Okay, number one, scene safety. That's where we're at with this. Okay, so let's say you get onto a scene and there's somebody who is having airway compromise, and you know you could either intubate that person, put a nasopharyngeal airway in them, or do something to help them, give them mouth-to-mouth, start CPR, and you don't have protective equipment. What should you do with this situation? Scene safety. Okay, you got to remember that, because it does us no good for 3 of you to get it and us have to all of a sudden have 4 patients rather than 1. And so we have to be cautious with this. If you're like at St. Vincent's, I know what they're doing now is they have 1 room they're intubating everybody in. And that, if you have to be intubated, you're going to go in that room. And they're not going to, you know, so we're not exposing other people if we can help it. We're not exposing ourselves. And so this is not a time to be a hero and try to go in and do things without scene safety. And so if you're doing aerosolizing procedures, you've got to have an N95 mask on. If you don't have one and somebody else is doing that procedure, you got to get away, okay? So if they're in it, say Joel's intubating somebody and you're trying to help him and you don't have a mask, you can't help him. I mean, you just can't. You got to get away, okay? And so it's just, I mean, we have to be careful with this, and it is dangerous. We got to take care of people, but we got to remember scene safety. Need to minimize the number of people who respond. If the patient sounds like they're pretty stable and doing well, then we're going to send 1 person in there. You know, we're not sending 3 people in there. This is not the time for students and ride-alongs and things like that. We want to minimize. We want to have as few people to take care of the person as possible. Does that make sense? You know, drivers need protection. What kind of protection do drivers need?
Mask.
So they need a mask for sure. Even if you're just driving, you're never going to be near the patient, you still need a mask, probably need glasses. Mask is the big thing. So the key is, if you did help out with the patient and now you're going to drive, what are you going to do?
Everything's going to come
off, right? You're going to
Everything's going to come off except the mask. The mask is going to stay on.
Perfect.
And then you're going to put anything that touches the patient doesn't go with the cab.
That's right. So you want to keep the cab as clean as possible. So, you know, if you got your 2 layers of gloves on and you take everything off, other than your mask, you've got a clean pair underneath there. You can go with that. Otherwise, you're going to put a new pair on and get in the rig. Okay, and so that's going to be an important thing. You know, we'll kind of get to some of the others real quick. Anything else on questions on PPI stuff? No. Initial contact, you want to try to keep 6 feet distance. Okay, what's your first thing you want to do with that patient? Come on. Get a mask on them. Yeah, you want to get a mask on that person right away. That's your number 1 thing. Grandma comes to the door and says, yeah, she's back here in the back. She's doing okay. Hey, why don't you put a mask on her and I'll be there in a second. I mean, you want that mask on that patient as soon as possible. That's going to decrease exposures immediately. So avoid touching your face. And they're doing studies on this, and it's amazing how many times we touch our face a day. Yeah, you're sitting there right now, right? It's like we just do it. And so it's hard not to do, but you know, you want to try not to, because this can get in from your hand to your lips, to your nose, to rubbing your eye. You got it, okay? And that's all it takes. We're not doing nebulizers, okay? So I know most of you guys don't do that, but we can give an inhaler, but we're not doing nebulizers. And so if they got a nebulizer at home and say, oh, can we do a treatment? No, because that aerosolizes the virus, okay? And then, so these are trying to avoid that contact. Yes, sir?
And that is with any patient or someone where you're suspecting?
So ideally, right now, it's coming, okay? We've been pretty protected so far in Montana and here, but we're not going to be pretty soon. So if you were in New York City right now, anybody you see, you're going to assume they have it, okay? And we'll get there. And it's probably safest and best if we have the gear to treat everybody that way from the start, okay? Because right now, I mean, you may have somebody who crashes their car who has this. And so then all of a sudden you find out 3 or 4 days later, well, number 1, they've exposed you, you've exposed your family, and it just becomes this public health nightmare. And so if we can and we have the supplies, we want to treat everybody that way. I mean, obviously, you know, there's a limit to our supplies, and we have to be careful with that. But you know, you do want to be as cautious as possible, and those are big things. Respiratory support, bagging them. We have filters. You guys have seen the filters. We have viral filters to put on. So you put that on. You got your mask, your filter, your bag, right? These guys know better, and so that is going to eliminate a lot of that getting through. Is it going to eliminate everything? No, because your seal is never 100%. You squeeze the seal. You know how they burp sometimes through the mask, where you blow a little too hard and there's not a good seal. You just shot a whole bunch of virus out. That didn't go through that filter. So it's better than nothing. Ideally, so in situations where the patient comes in and they're crumping, if they come into the emergency room at St. Vincent's or Billings Clinic, they're not going to bag valve mask them. They're going to put them on 100% high flow oxygen, and they're going to tube them right there, because intubation generates less of the droplets than bag valving them. We don't always have that option, so we may have to bag them, but those are things we think about. Intubation, you want the best person doing it that you got, because you don't want to have to do it multiple times. And so those are big things. So it's kind of this debate, you feel a little shaky on your intubation skills, somebody's really good at the hospital. Do you wait till you get there? And there's no good answer, but you do what you feel like you have to do at that point. If you're intubating, or if you're putting bag valving, if you're putting a nasopharyngeal airway in, doing these things, where's the ideal place to do it? In the back of the ambulance with the door shut and the heat?
Outside.
Open air. If you can do it, the more open air, the better. The more open air flow, the better. So if you're in the ambulance and you have to do it, and you can get the door open, vents open, whatever you can do to get open air, you're better. If you can do it outside, better. You don't want to be around other people, so you don't want to do it in their home necessarily if you can avoid it, but you do want to be in open air if possible. It's not always possible, but it is better. And those are big things. Questions on that? What about in the rig? What are we going to do in our rigs? I don't know if I have this on here specifically. What are we going to do in our rigs to try to decrease exposure to everybody in the rig?
Circulate air.
Circulate air. How are we going to do that?
With the vent system.
Okay.
Exhaust fan.
It's the exhaust fan in the back. What are we going to do in the front, though?
Roll the windows down.
You could, but you get a little bit of, you potentially could get some pullback and flow changes with that. The wind blows, you can pull air in. So realistically, you want the vents on, okay. Do you want it on recirculate the air or not recirculate the air? No recirculation. If it's hot outside, when you're in the summer and this is happening, how do you want to do your air conditioning? You guys have max air and air in all the ambulances? So when you turn it to max air, what happens then? Recirculates. So everybody needs to remember that recirculates. You don't want to do that. So you want that air flowing through. You want it on high flow. You want that door shut. Okay, those are big things. So the other things are, if you're exposed, people have to know. So public health has to know. Your medical officer, whoever's John, Tim, whoever's the lead provider on the call has to notify them. And we have to document all this because it has to be tracked, and those are big things. And because then we're going to base it on that low, moderate, and high risk and see where you fall and what we need to do with you as far as taking calls, not taking calls, and all those things, okay?
What if so the public health, but what if you're possibly exposed by somebody from another county?
Doesn't matter.
Will it eventually get back to you as a person to?
Oh, I see what you're saying. So you take somebody to Billings and they're from Yellowstone County and they end up positive down there. Will we be notified? Ideally, yes. They should. So the public health nurse in Yellowstone County then should track everything back, and they should track it back as far as even here, and they should notify us. They would call Sheila or those guys and let them know. Yeah. Now, that's ideally. Obviously, if it's crazy and we have hundreds and hundreds and hundreds of cases, maybe not. But at that point, we're all getting exposed anyways. Other things, documentation of all that. What you had on for your personal protective equipment. You need every item: eyes, face, gloves, and gown. What you did, what you didn't have on, because those are important for us when we weigh out what's your risk factors as far as exposure. Did the patient have a mask on? All those things need to be written down in there, ideally. Okay. Standard distance. How long is it? What do we do with the ambulance? So let's say we take somebody to the hospital, and we're working multiple calls. We got one ambulance to go back and forth in. We take somebody down, and we set them out at the hospital. They take the patient. What are we going to do then with our ambulance? Shut all the doors and chart. So while you're charting, you want it opened up all the way. Everything that can be open needs to be open so that air can flow through, okay? The 3-hour thing is in a stagnant room where there's no airflow, okay? So the more airflow, the faster, the better off we are as far as getting that virus out there. So you want the ambulance opened up when you're doing your charting, okay? So then you're done with your charting. You're gonna come back here, right? You should get in your ambulance. You want to wear your ideally put your mask back on because that ambulance is probably not completely clean yet. CDC says by the time you do your call, do your charting, get the ambulance back and clean it out all the way, it should be, the airborne part should be good enough at that point so that you should be able to then go get another patient if you needed to. And that's kind of their recommendations. If you keep it open and you do all those things, you should that ambulance should be aired out, and then you're going to clean all the surfaces, ideally with a mask, glasses if there's going to be any splashing, if you're spraying anything, and then you're going to clean out, and gloves obviously. You're cleaning all the surfaces, and then by that point you should be good. And that's kind of what the CDC recommends. So everybody got those sheets Tim sent out from CDC, yeah. And so you can read about that there too. And other stuff, other questions.
We're gonna talk about specific patient treatments.
Okay.
You know, for example, for that, all the different